ctDNA is a very interesting tool, also described as liquid biopsy, where we look for changes that and mutations and alterations on a molecular level in the blood of patients that have cancer. So we could use ctDNA liquid biopsies as a marker of, let's say, identifying resistance mechanism, molecular profiles of cancers while they're on therapy, and adjust our treatment approaches accordingly. I think one of the most interesting areas, though, where we use and will continue to use more and more ctDNA is identifying molecular residual disease or minimal residual disease. The question that we have in a lot of cancers, in particular colorectal cancer, is when we have patients with stage 2 and stage 3 disease that have tumors resected, we normally base our adjuvant chemotherapy decision on traditional clinical markers of aggressiveness of the cancer, lymph node involvement, lymphovascular invasion, perinodal invasion, T stage, etc. But a lot of patients really actually do not need adjuvant therapy because they'll never have recurrence. They're cured with chemotherapy, with a surgery alone. In other patients where we might not decide on chemotherapy based on the low risk tumor stage, might actually have recurrences. And we know we're missing out on some patients that should receive chemotherapy, adjuvant chemotherapy, which then have recurrences. On the other hand, also we, in the surveillance of patients after resection, we conventionally use CA as not a very highly sophisticated biomarker and tumor marker, and we rely on sequential scans every 3, 6, 12 months, up to 5 years in the surveillance part of the cancer. And I do believe that identifying molecular recurrences could identify patients earlier that might then require intervention, so that we can actually still provide a curative intent for these patients. So ctDNA as marker of molecular residual disease, minimal residual disease, is increasingly important to identify patients who are at high risk of recurrence where we normally would not do adjuvant chemotherapy. And then on the other hand, also identify patients who might not need adjuvant therapy, and which is a different question. And it can influence the way we monitor patients in the post-therapy phase, in the surveillance phase.